Good morning and a very warm welcome to everyone who's taken the time to join us for this morning's webinar, which is part of our Maternity Matters series at Irwin Mitchell. My name is Julianne Moore and I'm one of the partners here at Irwin Mitchell, and I'm delighted to be your host today, alongside my colleagues Rochelle and Rebecca. Rochelle, Rebecca and I are part of a specialised medical negligence team here at Irwin Mitchell who support clients and their families affected by birth injury claims. Our Maternity Matters series, which has been running now for 5 years since 2020, focuses on current key issues relating to maternity and postnatal care. The aim of these webinars is to bring together a community of participants in maternity care, be that patients, families, healthcare professionals, NHS trusts and charities, and the aim is to provide support, raise awareness and work to improve outcomes for all. Now, today's webinar is dedicated to the topic of maternal mental health. And this is a topic that touches not only the lives of those women and birthing people, but also their partners, their families, their communities, and the healthcare system as a whole. The journey into parenthood is often portrayed as joyful and fulfilling, but for many it can also bring challenges that are rarely spoken about. At least 1 in 5 women or birthing people experience mental health problems during their pregnancy or after the birth. And the purpose of today's webinar is to try and break down that stigma, share evidence-based insights and explore practical strategies for improving outcomes. This is whether you're a healthcare professional, a policymaker, an advocate, or a family member that's supporting someone that's going through mental health matters. And the session is designed to equip you with the knowledge and the tools to make a real difference. And through today's webinar and through our fantastic speakers, we'll explore how to recognise maternal mental health conditions. We're going to look at birth trauma and its psychological impact, and how to support women and birthing people, and how to signpost for appropriate care. A little bit about the running order. We're going to start off today with Sally Moore, who's one of our clients, and Sally will be joined by Rochelle, one of our partners, who's supported Sally and her family in respect of their claim, and they're going to have a bit of a fireside chat just for Sally to provide an insight into that lived-in experience of her maternal mental health following her child's birth injury claim. Then we'll go on to Dr. Rebecca Moore, who's a consultant perinatal psychiatrist and co-founder of Make Birth Better. And Rebecca will speak to us today about recognising maternal mental health conditions and the psychological impact of birth trauma. We'll then take a short comfort break of around 5 minutes, and then we'll come back, and our next speaker will be Nikki Wilson, who's the Chief Executive Officer of the Maternal Mental Health Alliance. And Nikki will discuss on how to support women and birthing people and how to signpost for appropriate care. And at the end of this session, then we'll move on to our Q&A panel discussion with all our speakers. Just a bit on housekeeping, as this is a live webinar, please could you keep your microphones on mute throughout the session. The webinar will run for approximately 2 hours. The webinar is being recorded, and at the end of the session over the forthcoming week, we will share the link with all registered attendees after the session so you can watch it back or share with colleagues, etc. In terms of questions, because we're keeping the session on time and we've only got 2 hours, there won't be an opportunity to ask the speakers the questions directly after each of their sessions, but instead we've created a Q&A function, which you'll find a button on your screen, and you can submit questions via the Q&A function at any point in the webinar, and then we'll address those questions at the end in our panel discussion. Also, if you're submitting questions, if we get lots of questions and we don't have time to answer them during the live session, please include your name and email so we can try and follow up those at the end. And then finally, at the end of the session, we'll share a feedback link. If you can take 2 minutes just to complete that, let us know your thoughts, what you'd like to see in the future as well. It helps us to shape those further webinars. So that's enough from me. Now I'm going to hand over now to Rochelle and our first two speakers, Sally and Rochelle, and then Rochelle will now introduce Sally. So thank you.
Thanks very much, Julianne, and welcome, Sally. I'm grateful for you joining us today to talk about Lexi, your second daughter. Just by way of background, to talk about the experience that Sally had. Lexi was born, she was fine, and became unwell when she was 3 weeks old. She was taken to the GP by her dad, and the GP recognised that she needed to be in hospital and immediately arranged for her to be transferred to hospital and seen by a doctor. That's sadly when things went awry, and she was seen by a very junior doctor, not immediately, but did not actually get escalated to a more senior doctor who recognised that she was potentially suffering from encephalitis. And so her administration of the drug acyclovir was delayed. Unfortunately and very sadly, by then the infection had gone to Lexi's brain, and she was basically then subsequently diagnosed with quadriplegic cerebral palsy. She's non-verbal, she's gastrostomy fed, and she is extremely limited in terms of her physical abilities. And I just wanted to talk to you, Sally, about those early days when you were in hospital. What did the medical staff... Sorry, could I just ask if somebody's got their microphone off mute? If you could mute, please, because we can hear a bit of feedback. We then, basically, Sally, what were you told in those early days in the hospital?
I can mine off mute, can't I?
Yes, you can.
Yeah. So when we first went in, it was very much they didn't know really what was wrong with her. And I remember being on an assessment unit for quite some time before we got allocated onto the ward. And she was still doing these little limb jerks throughout that period. It was only when we got on the ward, a nurse came in and she was like, just press this emergency button when you see your daughter making one of these movements that you're telling us about. So you'd press it and they wouldn't come in immediately. So by the time they'd come in, Lexi wasn't doing the movement. So then she'd go away and we'd do it. Literally, she'd just leave the room and we'd press it again. And that went on. And then after maybe like 5 or 6 times, she spoke to me like I was a little bit daft. She said, only press this button when you see her making one of these movements. I said, yeah, I am. But by the time she's doing another one, you've left and you're not near the room, sort of thing. So I don't know if they doubted. I don't know if they thought, I think they thought I was being a paranoid mum with this newborn baby. But yeah, as those next few days went on, she wasn't, she was still doing these movements, wasn't feeding great, just looked really, really unwell. And then I think we'd been in, I don't know, 2 days. I think we went in on Thursday, and it was on the Saturday our heart rate had dropped. And that was when they did rush her into their intensive care sort of room. And it was shortly after, and they'd been doing lumbar punctures on her and doing various different things. But I found that they were doing all these things, but I don't know whether it's their way, but not to worry us. Mm-hmm. So I was having to say, what's a lumbar puncture? And they were saying, well, we're going to put a needle in her back and it's just to check the fluid going up to the brain. But no one was telling me why they were doing it. I felt like they knew what was wrong with my baby, but they were waiting for somebody else to deliver that news. And they'd say, oh, well, the consultant's back on shift tomorrow. They'll speak to you then. And I felt very in the dark with it all. It was only because we had a neurologist family friend that I was just beside myself at one point. And my dad had said, look, we'll go and see their neighbour. And he said, and he ended up coming to the hospital on the Monday morning, but they still couldn't really give me any answers, and I felt like I was just being kept in the dark. But he assured me that if they know something, they will tell you it. But I think from my point of view, I felt like there didn't seem to be a lot of staff on over the weekend to ask any questions. I mean, I'm told that staff doesn't deteriorate on weekends, and it doesn't deteriorate on New Year's Eves and that sort of thing. But I was in hospital on New Year's Eve because Lexi was born on the 2nd of January, and I've had a baby there before. It did seem a lot quieter in there. You know, and this weekend I was in, there didn't seem to be as much staff on as there was Monday to Friday, and I was in there for 3 weeks. So I think for me, it's the not knowing, the constant not knowing.
Yeah, it's the fear, really, isn't it? And when Lexi came home, had you been told what you were going to expect in terms of her development, or were you just discharged and not given any information, really?
We was pretty much discharged because whilst Lexi was in, she'd had a brain scan. And they told me she's not got brain damage. So I was told she hasn't got any brain damage, which is good. They said she might have possible feeding problem. There might be something to do with the brain and the feeding. But when we left in the February, I just thought everything was going to be okay. And then about 2 weeks later, I got a letter to say, can you take her for a brain scan? And I thought, oh, I'll just take her for a brain scan. So I took her for this brain scan, and then they rang up and they said, can you come in? So I thought it was just going to be another chat. So I went off out. I'd gone for some lunch with my friends. And I said to Dave, could you just go to hospital and just see what they've got to say, thinking it would be absolutely nothing. And Dave rang me at the meal and he said, I think you need to get home now. And I said, why? And he said, she's got severe brain damage. So with that, we all just packed this meal up. I was beside myself at the table and I came home, and they still didn't really. I think it was in the summer. Again, I'd gone to a wedding and we'd planned to go to this wedding. I'd taken my eldest, who was 2 at the time. Lexi was not allowed to fly for the first year, they'd said. So Dave said, you go to your friend's wedding. Again, he went to another appointment and they'd said to Dave, she's showing signs of cerebral palsy. And then it was the New Year's Eve, 2 days before her first birthday, where we went for an appointment and they said, we're going to give her the terminology that she's got cerebral palsy.
So following that, Sally, as she got a bit older, you're now having to care for somebody who you're starting to notice that obviously when she was a baby, babies don't do as much as children who start to walk at 2 or a little bit earlier. And then she wasn't talking, she wasn't walking. Yeah. And at what point are you realizing that you're having to spend a lot more time, caring for your child as against your other daughter who is 2 years older, and she's starting to become a little bit more independent? Are you then realizing that you're at home, you're having to do everything for her? And how did that affect you and your life, which, before you were able to do more normal things?
Yeah, I think when they're little, even went up to that first year, in my head I was thinking, because I hadn't had that, so I'd never looked at. I remember when Dave mentioned the cerebral palsy in the summer, I never Googled it because I didn't want to go down that rabbit hole of looking into something that might not be. I don't know. In my head, I genuinely thought this little girl was going to just be delayed. And that, she might be 2 when she walks, she might be 4 when she starts talking. Because I didn't really want to, I don't know, I'm not nervous to find out I just thought I don't want to become one of these serial Googlers, and answer questions that might not have happened, sort of thing. But I think for me, when I first found it was getting hard was when she started at a disabled nursery, and I got this disabled pushchair that was really heavy, and lifting that in and out of the car, and the amount, for her to go into school, you had to have spare stiffs. You carry spares anyway, but I felt like she just had all this tons and tons of gear. And I think school were constantly sending her home, but I also still had another really little girl still at school who just started school. So having the two, I just feel like it's been utter chaos. And Lexi's nearly 10. Well, she'll be 10 in January, and Layla's about to turn 12. But I actually only feel like now I'm starting to realise that life's easing off a little bit, coupled with having carers in.
Yeah. But from a point of view, before this all happened, you had quite an interesting life in the fact that you travelled a lot. You go out with your friends, you were working in your father's business. How did the loss of all that sort of affect you?
I think when she first got poorly, my dad had just sold the business that weekend. So the two tying in together couldn't have happened at a better time, really. Because I don't know how I would have gone to work and had this little baby that wasn't very well, and have had a 2-year-old that was still very dependent on me. So I could just concentrate on being off. So I had every intention of going back to work, but I stayed off work on maternity for a year. And I think if I hadn't have had that maternity leave, I just don't know how I would have managed doing a job and what was involved. And after that year, I then decided, my job role had changed whilst I was off on maternity, which I think was a detriment to being off work. My role had started getting, people were taking bits of my job whilst I was on maternity leave. My desk was getting moved whilst I was on maternity leave. Nobody bothered to contact me whilst I was on maternity leave, like people who I'd worked with for 20 years in this family business. All of a sudden were not allowed to contact me anymore. I was getting locked out of computer systems. So I think for me, whilst I was off and knowing what I'd gone through in that first year, I just thought, these are not the type of people I want to go back and work for. I just think it wasn't very supportive. For me, it wasn't very supportive, and I'm sure other businesses probably would have dealt with it very differently. But for me, it was just not an environment I wanted to go back to, knowing how busy life would have been working full time and having these two little children, and one not very well.
And you didn't come and see a solicitor for a few years. I think Lexi was about 4 or 5 when we met. You weren't sleeping. You were up all night having to look after her. She wouldn't rest at night because if you left the room, she was very unsettled. How did that affect you? Never, being so sleep deprived and having to provide all the care.
Do you know what? I was very much. I just got on with things initially, and I just thought, this is the card I've been dealt. But looking back to how I am now, I was riddled with anxiety. I was tired. I was snappy. And that anxiety was just getting worse and worse. And I used to I don't know, I used to dread getting up every day. I used to think, oh God, I felt like it was like Groundhog Day.
Yeah.
But then I was still pretending to put a smile on my face to people and pretending, oh yeah, it's fine, it's fine, it's fine. And then when Lexi was about 6, I don't know, and I used to see all these families with disabled kids that, I don't know, you think they're happy. How are they doing it? How come I feel like this? And then I went through that spat. I just used to think, my life is just ruined here. This is just ruined for us. We can't we can travel, but it's chaos when we travel. But but I still want to go and do all these things. And, you know, Lexi was very unsettled. When I look now at, you know, we'd go for the days out, but it all revolved around Lexi. You know, she'd be sick, or, you know, it was just getting harder and harder. You know, I'm lugging this disabled pushchair into the boot of my car, and then all this stuff. And you'd look at my friends that maybe come on some of these days out or trips, and how easy it was for them to just go and do stuff. But then I look back at scenarios then compared to they are now, you know, and it's, some things are easier now. Certainly the weight of Lexi now, and, you know, wheeling her in and out of a van, and just making sure you've got everything with you, making sure she's warm, making sure she's not too hot, you know, everything. I feel like everything now has to be planned. You know, we're not a family that can just get in the car now and go on a journey. You know, we can't just turn up at somebody's house and sleep the night. You know, all those factors have to come into it now. It has to be a little bit more planned.
And I know that you did manage to get some respite care, but a lot later. Did things suddenly hit a sort of brick wall for you that you just really couldn't cope anymore?
Yeah, I think for me, I remembered my other half being away, and I was trying to pack to go on a trip, and I had both kids off in the day, and I was trying to go on this trip, but having Lexi, and, you know, you just get one feed done. She wouldn't sleep great unless she was on me. You know, so I just felt like I couldn't get anything done at all. And then people would be saying, do you get direct payment? I was thinking, I've got nothing. No family help. We've got no siblings near us. You know, I was constantly having to rely on friends. So I was trying to pack for this trip, and I remember ringing this children's centre to say, somebody's told me about. I think actually that day I'd taken both children to cinema. Then from the cinema, one was at the dentist. But then I remember an NHS occupational therapist was at the house, and she was like, hello, I'm at the house. Where are you? So then I literally bundled these two kids up out the dentist, and I was like, I'm going to have to go. And we left the dentist, came back here for this appointment. And I just thought, what am I doing? This is just utter bedlam. And yes, I'd forgotten the OT was going to be at the house, but, you know, just even going to the cinema with two little kids, and Lexi's posture, she was sliding off the chair. She then was wriggling around because she was getting excited. So I'm trying to keep her in, trying to keep the other one. And I just, days out like that would just be would just be getting a little bit more unbearable. So I rang this number and I said, you know, could I have an assessment for direct payment? And she said, could you tell me what it's for? And I said, well, I can't get anything done. I'm trying to pack to go away. She like half laughed in my face, this lady, and she was like, pack to go away? And I said, yeah. And she said, well, we've got families who can't do stuff like that. So I put the phone down and I just left it. I thought she made me feel like I was some kind of jumped up little princess that was off on holiday. So I never did anything for ages, but then all the more I would see families out with what looked like a carer or somebody that wasn't family. So I would go and ask, do you get direct payment? And they'd say, I'm a direct payment worker. I'm not mum. So I just did a little bit more investigation work, and I met another Erwin Mitchell client through my OT when we came to having some adaptations done. And it was her that said, I'd met her twice. So I'd met her this first time, and then I went and met her again. She said, have you had those notes of yours looked at yet? And I said, no. And she said, just go and meet Rochelle at Erwin Mitchell and just have them looked at. But she said, yes, we get direct payment as well. So, you know, when I got these, I think it was 6 hours direct payment, I thought I'd won the lottery, literally. I couldn't believe that somebody was going to come in my house who I could trust and I was able to leave this little girl with, and that Dave and I could go out with the other one for 6 hours. I just couldn't believe it.
Yeah.
And then it went to 8 hours. And then it went to somebody's going to come into your house and have them overnight. We initially was like, oh, that's a bit weird. You know, and those hours did increase to 14. So I think I ended up then swapping the day for the night, and then we would pay the difference a little bit out of the DLA. You know, and I look to what we've got now compared to them, you know, and it's astronomical, the help I get now.
Yeah. It was a lifeline for you, Sally. I think we're coming to the end of time. I'd just like if we can change the slide and show a little photograph of Lexi, who's beautiful. That'd be lovely.
I just wanted to show those slides there of, you know, for me, it doesn't have to all be doom and gloom. You know, I've gone through periods of it being doom and gloom and not thinking there was, you know, life was never going to change, and how unhappy I've been. Can't speak for Dave, but, you know, I have been seriously unhappy in the earlier days, and I feel like I've come out the other end. You know, I might have nearly cracked up at one point, but, you know, I think you can see from there, we're on holiday. We have lovely holidays now. You know, Lexi gets to experience going on a bike. She gets to experience ski trips, you know, all things that I never thought was going to be possible with a child with a brain injury. And, you know, being given those opportunities now, you know, I'm going to do as much as I can with her instead of going down life's ruin sort of thing. You know, we're going to still do the same things, and I'm still going to lug this child on a flight for as long as I'm able to, and let her come on holidays and things. So yeah, it was just to show everybody that it's not all doom and gloom anymore.
They're beautiful photographs. Thank you so much, Sally, for sharing that with us.
Thank you.
And I'm now going to hand back to Julianne to introduce the next speaker. Thank you very much.
Thank you.
Thank you so much, Sally, for so bravely sharing yours and Lexi's story, and to Rochelle for guiding us through that journey. I think hearing firsthand the account, the impact on Sally and the family has been really incredibly insightful. And I think it's a real powerful reminder of the realities about caring for a child with severe disabilities and the impact on maternal mental health. And I think we can all take something very meaningful from your experience. So thank you for sharing that, and great at the end, you know, showing, you know, Lexi and those wonderful photos. So thank you very much for sharing your story. So we'll now move on to our second speaker, and this we're going to introduce Dr. Rebecca Moore. I call her Becca. I've known her for many years, so I'll probably use the word Becca if that's okay. So a little bit about Becca. She's a consultant perinatal psychiatrist, but she's also the co-founder of the birth trauma charity Make Birth Better. A little bit about Becca. She specialises in offering one-off and long-term care for women and birthing people with mental health issues such as anxiety, depression, OCD, especially during the perinatal period. She also offers preconceptual advice and reviews. She's got an immense amount of experience and expertise around birth trauma, and real, you know, fantastic history and extensive history of guiding women and birthing people through pregnancy and postpartum. She's been featured in lots and lots of books. Just a few of those would be The No Guilt Pregnancy Plan, The Mother's Book, and Bridget Hargreaves' Fine Not Fine and The Mother of All Jobs. I particularly like the title of that last book. And she's also, you'll see that she's contributed to many pieces in the national press and appeared on a number of TV programmes, etc. So thank you very much, Rebecca, for joining us. And I'm going to hand over to you now. So thank you.
Thank you so much. Can someone share my slides? Is that okay? I think that's brilliant. Thank you so much. So thank you very much for that introduction, and thank you, Sally, for sharing your story as well. I am going to be talking for about half an hour on just a general kind of overview around perinatal maternal mental health, and really thinking about why it's important, what we might look for in people that we know that might be having signs and symptoms, and how it can impact why it's so important that we offer this kind of specialist care for families as well. Thank you. Next slide. So just a little bit about me. Obviously, Julianne has already said some of that. So I've been a perinatal psychiatrist since 1999. And at that point, really, perinatal psychiatry didn't really exist as it does now. So there's been an explosion in awareness, which is great. I'm also the co-founder of Make Birth Better, and we're a collective of parents and professionals that campaigns around perinatal trauma. And trying to reduce that for people not only being cared for within the system, but also working within the NHS as well. I'm lucky enough to be a mum myself. I had hyperemesis in all of my pregnancies, so that is something that I can deeply sympathise with, where people have suffered with hyperemesis. And also I have had pregnancy losses myself, and I have a family history of mental health issues. I'm also known in our team as the research geek, so I absolutely love research, and certainly there's been an explosion of research and thought about how we support families, which is brilliant to see. And I always describe myself as being an agitator for wanting to campaign for and work towards having better maternity care for all and equity of access for all as well. Thank you. So why perinatal mental health matters? I'm sure that many of you will be aware that when we're talking about the term perinatal, what we're really talking about is any time as soon as somebody's pregnant up to a year postnatally. And in fact, some of the newer NHS teams and services also work up until 2 years postnatal now, which is brilliant. So we're able to offer this really extended period of support for people. It might be that sometimes people have a known mental health issue, and then pregnancy with all its kind of changes and transitions becomes a more vulnerable period for them. But for many, many women and birthing people, it can be the time of a new onset of mental health symptoms. So they've never had any mental health issues before. And there are a whole heap of things that we will be looking for and assessing and treating. I'm trying to cover as many of those as I can within a very short talk. But really the commonest things that we would be looking for and seeing would be depression, anxiety, also things like obsessive compulsive disorder, birth trauma related changes for people, and then more rarer things like postpartum psychosis as well. And we know that for many people, particularly in pregnancy and postnatally, that illnesses can come on very quickly and people can become unwell very, very quickly, but they can also get better really, really quickly, which is why we want to put in that specialist care as soon as we can. We know that maternal suicide remains one of the leading indirect causes of death for women in the first year postnatally and within pregnancy as well. And we also know and increasingly look for families, not just mums. So knowing that partners can also be impacted with all of these issues as well. So they can also find birth traumatic. They can also suffer from depression and any of the other diagnoses that we're going to talk about. So there's a real switch to looking about family health, which I think is absolutely brilliant. So we should be thinking about everybody in the family and how they're doing in that kind of transition to parenthood. Thank you. So there are lots and lots of myths about parenthood and mental health. When I was first training, I was told that pregnancy was a protective thing for women and that they couldn't possibly become unwell, which of course we know is a myth. We know that anybody can be affected by mental health issues during pregnancy and postnatally. We know that the impact of their mental health is in no way a reflection of their ability to be a parent. We know that across the board of really across the world that these conditions can affect anyone from any different background or country, and that they really seem to occur consistently wherever you look across the world. So lots and lots of myths about pregnancy and mental health that we should be aware of and always be able to challenge if we hear people talking about them ourselves. This comes from the work of the NCT, and it's a really nice document. You're very welcome to have a copy of my slides from this talk as well, if that would be helpful. Thank you. Next slide. So as Julianne alluded to at the beginning, why this is important is because it's really common. Lots and lots of people will be affected with a change in their mental health during pregnancy or postnatally. And we know that from the biggest reviews worldwide, that postnatal depression is incredibly common. There'll be a range of that from a sort of milder episode for some people up to really severe episodes where people might need to be admitted for inpatient treatment. So this is something that is going to affect lots of people that we are working with and caring for. So we should always be holding it in mind and thinking about screening for it wherever possible. Thank you. Next slide. We know also that there are lots of barriers as to why sometimes people are afraid to talk about their mental health. And with mental health in pregnancy and as a new parent, I think there's always a kind of double whammy of stigma. So there's all the normal stigma and shame and fear that people might have about talking about their mental health in general. But there's also a double layer because you're about to be or are a new parent. So added onto that is all the fears that people have about being judged to be a bad mum, about failing as a parent. And the commonest thing that everybody talks about is this fear that, somehow their baby might be removed from their care. And this is a really big issue in perinatal mental health because we know that around 50% of people will never come and see a professional about their mental health. They will struggle on in silence. And that's why all of us, wherever we work, even with family, with friends, I feel we have a responsibility to check in and look after our new parents because a lot of them will be struggling in silence. It's also where the explosion of things like peer support and online resources can be really, really brilliant in starting those conversations and allowing people to talk to other parents that have had similar issues and not feel judged or shamed. Next slide, please. Thank you. So why we want to treat people and treat people rapidly and with specialist care is we know that if you have a woman who has an untreated mental health condition that started perhaps in pregnancy, we know that that can lead to them not engaging with antenatal care. They might be self-medicating with alcohol, and it can also lead to kind of complications within the pregnancy itself. So they're more likely to have smaller babies, premature babies, babies that might need to go on to NICU. And we know that then there is also not only an impact for mum, but also for the baby. So sometimes if you're being parented by somebody who has an untreated depression or anxiety, say, then there tends to be an impact on that parent-infant connection. And longer term, it can lead to specific changes in terms of the baby's development, so cognitively. And then you get that real kind of intergenerational pattern going on where if you look at the cost of not treating women for their own mental health through the perinatal period, 75% of that cost becomes a cost for the child, and they're more likely then to have their own mental health issues, to have issues with the police, to have issues with substance misuse. So this is truly so impactful. If we treat the mum, we influence the whole outcome for her family as well. Thank you. Next slide. So I'm going to go through and talk about, it's a bit of a whistle-stop tour in half an hour to try and talk about this massive topic, but just to really think about some of the commonest presentations that we will be likely to be seeing in our roles, or just even as friends, siblings, partners. So most of the focus on raising awareness around perinatal mental health initially started around depression, rightly so, because it is incredibly common. And we know that depression often starts antenatally for people, actually, if you track back and talk to them. And that if people are depressed antenatally, they're much more likely to have more significant postnatal depression as well. We know that it's really common for women and birthing people and partners. So really, you know, it's something that we're probably all aware of, a lot of the signs of depression. And we do screen for depression during pregnancy in terms of a midwifery screening. But really what you're looking at is somebody just feeling constantly low, not enjoying things, not wanting to do things, perhaps feeling tearful, often comes with a lot of guilt and shame, particularly around parenting, perhaps. And then you might see that people are struggling to sleep, they can't eat, they might lose weight, they just can't focus on things. And at the more extreme end, people can become very suicidal and have, you know, specific plans to harm themselves as well. Often the best narratives of depression or any mental health condition sometimes comes from people's partners or family. Sometimes people can't see it themselves or say it themselves. So it's always worth talking to family as well, because they will normally be able to say, they have really changed, they're just not themselves, something's not right. So involving families to get a different history can be really, really helpful as well. Thank you. So just to give a kind of overview of, you know, some people that I've worked with who have changed their names, but they always allow me to share their stories. But depression can come from lots of different causes. So for this first lady, she had had a difficult birth and then was physically unwell with sepsis. That meant that she was not really as present with her baby initially as she had expected to be. It impacted her being able to breastfeed, and she just felt progressively lower and lower in mood as a result of that. The second lady had become very quickly depressed and really within days postnatally was feeling very, very low, just felt completely overwhelmed. And again, that sense of kind of shame, she felt she was failing. Both of these cases ended up taking medication. Both of them got well really, really quickly, and had also had support from perinatal mental health teams in terms of nursery nurse support and people going out to support them at home as well. Thank you. You can just get a pure anxiety, and actually perinatal anxiety is much more common than was once thought. So it's worth checking in with people about whether it is anxiety that's there rather than depression. Often people will be misdiagnosed. But with a pure kind of anxiety disorder, people don't have that low mood, but they just feel constantly worried, anxious, might feel kind of hot and sweaty and panicky, restless. Sometimes they might have problems eating, lose weight, have diarrhea, have, you know, just feeling constantly wired and on edge all the time. We all have probably at some time in our life felt that sensation of anxiety, but a clinical anxiety is where it's just there all the time, from the moment you wake up till the moment you try to go to sleep. It's about that kind of intensity and it being a day in, day out experience for people. And it's just a really horrible, uncomfortable feeling as well. Next slide, please. Thank you. So obsessive compulsive disorder I wanted to mention because it is, again, actually something that is often triggered by pregnancy and postnatally. We know that sometimes people might have had a prior history of obsessive compulsive disorder, but then for a lot of people, it's a new onset in pregnancy as well. You can get a mixture of obsessions and compulsions. So the obsessions tends to be the thought part of it. So thinking in a way that feels really uncomfortable to you, like a constant thought of worry about perhaps harm or cleanliness or risks in some way. And then to try to kind of neutralize that intrusive thought, then sometimes people will develop compulsions as well. So the classical one would be where somebody is worried about contamination and germs, and they then begin to hand wash over and over again to make sure that they are clean, or they won't touch certain things, or they're wearing plastic gloves. But you can imagine that if this is going on for you when you're pregnant or also trying to parent a newborn, it can be an incredibly difficult thing. OCD is one of those conditions that can actually get really severe in pregnancy, to the degree where I have looked after people that have needed a hospital admission because of their OCD during pregnancy. Next slide, please. Just to give you an example of that, so this was somebody that I was working with who'd had no mental health issues at all in the past, and she developed OCD postnatally, and she just became preoccupied with the fact that she had somehow harmed her baby or might harm her baby. And that was things like she wouldn't carry the baby because she was so frightened about dropping the baby. She wouldn't feed the baby because she was worried about the baby choking. She wouldn't put the baby in the bath because she was worried that she would let go of the baby and the baby would be hurt in some way. And she just was constantly asking her husband and family for reassurance that this hadn't happened. So an incredibly difficult thing to experience. For most people with OCD, they often need a combination of therapy and medication, but with the right treatment can do really, really, really well. Next slide, please. Thank you. I just wanted to touch on puerperal psychosis because although it is very rare, it is a psychiatric emergency. So it's something that everybody should be aware of. All of these women will need an inpatient admission, usually to a mother and baby unit for specialist treatment and support. It tends to happen around 1 to 2 women per 1,000. So if you think about any big hospital that might have anything between 5,000 to 12,000 births a year, then there will be cases of puerperal psychosis each year. And often these women get missed or misdiagnosed, and they are a group of women that probably will start to evolve the symptoms when they are still an inpatient under midwifery care. So you typically get a really, really dramatic change in somebody's mental health, often within 2 or 3 days of giving birth. And it's what we call a cycloid psychosis. So it's a fluctuating psychosis. So these women can seem fine one moment, tearful the next moment, angry the next moment, delusional the next moment. It's a really, really striking up and down change, often really dramatic and often with a lot of psychotic symptoms. So feeling paranoid, feeling that their baby's been swapped, feeling that someone's trying to harm them on the ward. Really, really striking and dramatic. Once you have seen someone with a puerperal psychosis, you will never forget it. And they absolutely need to be admitted because often their delusional beliefs will become a risk of harm for them and their baby as well. It often runs in families, and it is something that is more common in first-time mums who have perhaps never had any mental health issues in the past at all. Next slide, please. Thank you. Obviously, there are also some other women that we know have a mental health issue coming into pregnancy, and that might be something like schizophrenia, bipolar, an eating disorder, so things that can be triggered and flare up in pregnancy or postnatally. I just wanted to particularly flag up bipolar women, sometimes called manic depression, but these are a group of women that absolutely need to be with a perinatal mental health team in pregnancy, primarily because they are at incredibly high risk of relapse, mainly postnatally. Even if they're medicated and taking medication, 50% of them will have some kind of change in their mental health postnatally. So really, if you're ever working with anybody or know of anybody, they're a group that need absolutely specialist care and support through their pregnancy and afterwards, as they can become unwell really, really quickly. They can present with depression as well, but I think when they're in a manic phase, it's a group where they are not sleeping, not eating, full of energy, spending money, think that they have some special powers, perhaps talking really, really fast. Those would be the kind of classical presentations when somebody was becoming manic. Thank you. I also just wanted to mention women with physical health issues, particularly for our midwifery colleagues today and obstetric colleagues. There's a lot of, growing awareness of how having particular physical health issues during a pregnancy can significantly impact on somebody's mental health. So, particularly hyperemesis, for example, but also if somebody is struggling with pain or perhaps even a new onset gestational diabetes. We have to move away from this separation of thinking things are physical or mental. They're not, they're intertwined. And if somebody's been physically unwell through a pregnancy, it can have a significant impact on their mental health, understandably. Also, in some of the EMBRACE reports, which are the studies that look at why women die during pregnancy, just to be mindful of the fact that sometimes psychiatric illnesses can present or be misdiagnosed as a physical health issue and vice versa. So holding in mind and thinking about both is really, really important. Thank you. I'm just going to touch on perinatal birth trauma, which is my real kind of love and expertise. I could talk about this all day. But I think it's really important to talk about because so many women and birthing people currently are coming away from their maternity experience feeling traumatized for a whole range of reasons. And for 1 in 3 women, that will cause trauma symptoms which can last for months or even years. It can cause them to delay having another pregnancy, and for a smaller proportion of women, they will go on to develop a postnatal PTSD, which again needs its own treatment and assessment. We increasingly think about perinatal trauma, not birth trauma, because trauma can occur at one or multiple times throughout someone moving through the maternity system. So it might be around infertility or pregnancy loss. It might be about the pregnancy. It can be about the birth if you feel things are out of control, you didn't feel cared for, your pain wasn't acknowledged, there was racist care, or it can be postnatally where you felt perhaps that you couldn't feed as you expected, or baby needed to be on NICU, for example. And when people have gone through such a traumatic experience, we tend to see that they either become very preoccupied with talking about the birth all the time, or might be replaying it, might be having nightmares or flashbacks, or people can't just think about the birth at all. They can't talk about it. They don't want to go near the hospital. They don't want to see pregnant friends. They can feel very angry. And so it can have, a profound impact on people's mental health. So just to hold in mind that also somebody might develop a depression, but the root of that might be a traumatic birth experience. So we should certainly be much better at listening to people about how their birth experience was. And for many women, once they've left midwifery care, this is just not explored with their GP or health visitor. And sometimes we're missing the root of what's led to depression or anxiety because it's actually been that birth experience for somebody. Thank you. We also have to think about how we might cause trauma for people in the systems and spaces that we work at. So, you know, this comes down to things like offering continuity of care so people don't have to retell their story all the time. It can be about the language we use, can be about things like obstetric violence, about not collaborating with people, talking above people or about them, but not with them, you know, not including partners. So there's a whole heap of things to think about with trauma as well, about our role in that and what we can do to reduce trauma for people that we are caring for. Next slide, please. Thank you. I just wanted to touch on perinatal red flags. These are things that wherever you're working, if you ever see a woman with any of these, that you should be seeking urgent support and advice about. So this is if there has been a really dramatic change in someone's mental health within days, if there's been any thoughts that are unusual about the baby, thinking the baby's not theirs, thinking the baby is possessed, thinking that you would be better off if the baby wasn't anything to do with the baby, needs to be an urgent referral for specialist support. And anything where family are saying they're just not right, it's really out of character, they're behaving really oddly, but also specifically things like people who mask really well. So the group of women that are most at risk often, my consultant always used to call the women who wear lipstick. So it's the professional, married, smart-looking women who appear to be functioning really, really well, are often a group that mask and actually underneath are profoundly unwell. So just really thinking about these red flags and seeking support if you have anybody that fits any of those criteria. Next slide, please. I'm just going to touch on suicide. I'm aware that this talk may seem really heavy, but we can't not talk about these things. And I know that Nikki's talk is probably going to give the balance of, you know, where we are with services and how amazing services are and development of that. But just again, to think about myths about suicide, because I know it's something that people often feel really worried about asking. There is no evidence that asking about suicide raises risk. In fact, for a lot of people, it's a huge relief because they've never been asked. So if anybody's expressing those ideas, whatever your role or competency, you don't have to dive into detail, but just acknowledging that you've heard that they're feeling like that, and that you will help them to find the right support can be really healing and life-changing for people. So, you know, it's not only professionals who can hear that. Sometimes people will disclose to us because we're a friend or they feel comfortable. We can then guide and signpost people to the correct specialist support. But if we close people down, they may feel that they can never mention that again. So just to be aware of the fact and the myths around suicide as well. Next slide, please. Thank you. I think this is nearly my last slide, so I've just brought it in on time. I will stay till the end, so we've got time for questions as well. But just thinking about pathways, I know Nikki's probably going to talk about this, so I'm not going to go into big detail, but really thinking about wherever you are, find out about your pathways. And that is pathways of care, both within the NHS, but also outside of it, like the peer support that I've mentioned as well. Know how to refer. And as a clinician, I would say, do not ever worry about having a conversation or making a referral. If in doubt, pick up the phone and have a conversation. Trust your instincts. If there's something niggling, you know, that you're worried, no one will mind you having a quick conversation about that. Better to do that than not. Just to touch on medications, please don't tell anybody to suddenly stop medication if they're pregnant or breastfeeding. Get urgent support from your perinatal team or your pharmacist because most medications can be taken safely through pregnancy and breastfeeding, and it's far more harmful for people to suddenly stop and relapse. So please seek support first. Just hold in mind the whole family, not just mum, because often partners can feel very sidelined or be having their own mental health issues that are not identified. And then think about, those perinatal red flags we've spoken about. Also, the recent Embrace reports have kind of highlighted other risk groups of women that we should be holding in mind, thinking about the need for good translators and thinking about women that have multiple disadvantages, that they are actually a high risk group. So really thinking about how we work to support those groups of women as well. Next slide, please. Yes, last ones I think is just, I did want to mention about Embrace. So they collate every 3 years women, who die in that perinatal period and thinking about why. And just to highlight that the most recent report picked out this group of women that are particularly vulnerable, and really it's for us to think about our services and care and interaction. How do we support these group of women that are most vulnerable? I'm sure you're all well aware of the statistics, that differ between Black, brown, white women. So what are we doing about that? But also there are a group of women that have multiple disadvantages that are beginning to be the group that are most at risk of suicide. So they're a group where there's perhaps multiple teams involved. There might be substance abuse, domestic violence, social services involvement. And what we often see is that they have numerous services involved, but none of them are actually talking to each other. And therefore, women get this really patchy, disjointed care. So just holding in mind these as a really high risk, vulnerable group of people and thinking about how we support them as well. Thank you. And that's just what Embrace is saying. You can look at all the reports, but this is all the things that probably we know around kind of training, raising aware, integrating care and support, and thinking about how we record risks and data and share those together as well. I think that might be the next slide. I never know, there might be one more. That's the last one, I know that. Just some resources there. I wanted to flag our resource on Make Birth Better. It's a toolkit that anybody can download. It lists all the common symptoms that people might be having, one for women and birthing people, one for partners. And it's a thing you can tick and take to your GP or health visitor or midwife to start a discussion around mental health. Pandas is run by people with experience of perinatal illness. They have an amazing helpline, phone line. Maternal Mental Health Alliance, Nikki's going to talk about that more. And obviously our own website at Make Birth Better has a ton of resources around trauma and seeking support, both for parents and professionals. And I'm only 2 minutes late, Julianne. There you go.
That was fantastic. Thank you so much, Becca, as always. You took us through, I know you could probably talk about maternal mental health for probably a few hours. And so to take us through your knowledge and, you took us through it very succinctly, identifying those mental health conditions that can arise during pregnancy and the postnatal period. And I think it was really helpful with putting out some of the red flags, for people to be aware of, so we can try and help identify and support those individuals as soon as possible. So yeah, what we will try and do is also put some of those really helpful links that you put on that last slide. When we share the recording, we'll try and create a slide so we can put those on so people can access those resources very quickly. So thank you very much, Becca. Just to remind people, we have got the Q&A function. So if you've got any questions for any of our speakers that you've heard so far, please post them in the Q&A chat function that you should have access to, so we can use those to help shape the panel discussion at the end. So we're going to move on now to a quick comfort break. We're probably aiming to do about 5 minutes. So if you can all come back for about 7 minutes past 12, that will allow us hopefully for you all to take a quick break and hopefully get a cup of tea, and we'll see you with our third and final speaker before the Q&A. So thank you. Welcome back, everyone. Hopefully that's been 5 minutes. So we're just going to move on to our third speaker now. And I have the pleasure of introducing Nikki Wilson, who is the Chief Executive of the Maternal Mental Health Alliance. Just a little bit about Nikki, who we've also had the pleasure of knowing for many, many years. She has a very impressive third sector career spanning over 20 years, and she successfully tackled many organisations and built some really impactful ones from scratch, including Wings for Life, Read International, and latterly Make Birth Better. She's now moved on to the Maternal Mental Health Alliance, and over all her time, Nikki's held a very long-standing passion for leading social change. And she's also got a very, very deep commitment to perinatal mental health, which is shaped by her own lived-in experience of birth trauma and PTSD. So just to say welcome, Nikki, and hand it over to you.
Thank you, Julianne. Thanks for that lovely introduction. It's nice to be here with you all today. I'm just going to do a supposedly seamless screen share. Give me 1 second. She says. No, that's not it. 1 second. It was showing up just before. I need to just check where it's gone. Okay, I think this will work. 1 second. Share window. There we go. Okay. Okay, I think that's good now. If I just press share, present, I think you should be able to see the slides. I'm going to assume yes, because it all looks right to me. So yeah, thank you for the introduction, Julianne. Let me tell you a little bit about the Maternal Mental Health Alliance before we move into the rest of the deck. I'll check my phone as well to make sure I don't overrun with my time. So the Maternal Mental Health Alliance is a UK-wide charity and collaborative network. We're very much united by a vision, which is all about excellent mental health care for mothers and birthing people. And of course, care can be provided in a multitude of ways. And at our alliance, we've got a range of individuals and organisations all working in the mix together. So we've got a group of members that number over 160 now, which is community groups, national charities, professional bodies. We have an incredible network of lived experience champions. We have about 50 of them telling their stories in lots of ways and formats. And we have a really incredible range of professional experts, political allies, and then a whole host of wonderful other supporters sitting around us too. So I'm just going to talk you through what makes the perinatal period uniquely different to any other particular period when it comes to mental health. Then we're going to talk about how to find excellent care support services, and then we're going to talk a little bit. I'm just going to finish with some big unanswered questions, perhaps that we could roll into Q&A, or that you could just ponder over. So let me just span all the way out to start before we go into perinatal mental health. So mental health, and this is a direct lift out of this recent report from Mind. They talk about mental health in this country being at a crossroads. Essentially, as a high-income country, we're spending hugely more than low-income countries around the world on mental health. So we really are very fortunate to live in a space where these conversations are happening and services are being funded by our governments. We've had huge progress in the UK in particular, particularly in the last kind of 10 to 15 years, and that has been backed by funding, sustained funding from the government and also third sector as well. What's interesting and unique to the UK is that we are seeing our mental health problems in fact rising faster than they ever have been. Meanwhile, our services are beginning to get very overstretched, and in some cases the stigma in fact is not getting less, it's getting worse. And just to give you a sense of, whilst our government has been committed, I'm sure it's no surprise that there is a big gap. So we think that about 20% of the disease burden, to use a formal term, relates to mental health, but less than 10% of NHS spend is now spent on mental health, and unfortunately that number is dropping. So there are lots of factors that make you more vulnerable to experience poorer mental health. And this diagram just shows the main ones in the mix, again, at a very kind of headline level. So if you're living in poverty and debt, if you're a younger person, if you have issues with your physical health, if you'd experienced any kind of adverse childhood experiences, if you're unemployed, all of those things are going to make it more likely that you experience a mental health condition. But I've put here women in green on purpose because this is, and whilst Becca absolutely rightly said, and we should always think about the system of people involved in mental health, not just the woman or the birthing person, there is something that is important to hold on to that is quite unique to women. So as a woman, you are more likely over the course of your lifetime to experience a mental health problem than men, particularly pertinent in young women. So that's where rates go up really quite significantly compared to young boys. And then also perinatal women in particular will come on more to these stats and facts as we go through. And therefore that makes young mums particularly vulnerable, just as an example group of a group that tend to be more marginalised and are often more at risk. So the perinatal period, as Becca described, often it depends how you want to frame it. But if you just think about that really from the moment at which you decide that you may want to become pregnant, or perhaps the moment you fall pregnant, whether that was on purpose or not, all the way through to that 1 or 2 years after is what we're talking about, is this perinatal period. And it really is a very, very unique time for our minds and for our bodies, for loads and loads of different factors are at play here. So hormonal shifts, identity changes, social transitions, lots going on. And all of that together really amplifies the mental health risk. So just talk through 3 particular areas briefly. So, in terms of your physiology and your neurology, a lot is changing that increase that level of risk. So we know, don't we, how our hormones affect our mood and how much hormones shift in this perinatal period. Sleep, of course, is a really critical part of healthy brains and healthy mental health. So when we're getting less sleep, we're more vulnerable. There are some really unique conditions that actually only occur during a perinatal period that are linked to mental health problems. So, for example, like hyperemesis gravidarum, that can only happen in this period. Birth injuries, of course, as Sally talked about earlier, and the impact that they can have on the mental health issues faced by the parents. And then also brain changes. I love this. I'm actually a psychology and neuroscience graduate back from 20 years ago, so I love everything about the brain. But I think what's really interesting is with more and more brilliant kind of neuroscience studies, we're seeing that the way the brain changes in this period, the way your grey matter and the white matter in your brain changes, it is marked. It's very measurable. And we know that what that does actually is it changes your brain. So there is a period within which you're going to feel quite naturally more vigilant. You're going to feel quite naturally a much greater sense of responsibility. You're going to feel more driven by bonding. And those things make you more emotionally vulnerable. Increased exposure to traumatic events. Becca's touched on this, but there are a lot of things around in this time period that people may themselves, and it's always their perception, may find extremely distressing. So that, of course, can look like pregnancy, baby loss, fertility struggles. It goes without saying, of course, domestic violence incredibly difficult, but it's really important to know that domestic abuse increases by 30 to 40% during pregnancy and in the postpartum period. Fear of birth is a very real thing. Again, all of these stats depend on what measure you put on them, but we know that a very high proportion of pregnant women report some level of fear of childbirth. Intervention trends are changing. We know we've got higher rates of induction, assisted delivery, cesarean births, which unfortunately do often lead to more traumatic birth experiences. And then 1 in 3 women feel in some way traumatized by their birth. And then there's all these other factors at play, and it is really important that we think about these in the mix of everything that's going on. So we've got all of our old and our new growing expectations and narratives around this time of our life. So the health of the baby always comes first. That's a real kind of old school narrative that still really holds strong. But for those of you that are really into this, I imagine none of you are probably quite as into this as Becca and myself, but do look up the work of, I'm just going to make sure I get the reference right for you. Do look up work from Hayes and Miller around intensified motherhood. This is a really interesting new way of trying to put words to a very big cultural shift that's happened for us, and particularly in our higher economic countries, where there's this real cultural ideal that's been developed, which is about mothers having to be very child-centered, very expert guided, very emotionally absorbed, and their time and the finances should be kind of very much driven into the child themselves, with the responsibility very much sitting on the mother in particular. These are really new but changing and important to be aware of narratives that are around for us as a society. Of course, working, most people are living in households that require 2 incomes, and yet stigma persists around working women. And of course, career breaks can really erode any sense of identity or security. Digital overload piece is, of course, something that we're all always talking about. Great new fact someone told me recently is that it has been proven that as an average, people are more likely to take advice seriously that they receive in WhatsApp groups than they are from healthcare professionals. So there is something very much changing here that we all have to be on board with and understanding. Of course, isolation is very real. And the changing profile of our age when we become mothers is also affecting our mental health too. And of course, it's very normal that this is a time when there can be a lot of relationship strain. So Becca's covered this, so I'm not going to go into any particular detail on this, other than to say I, under MMHA, we find it quite useful to think of this in a triangle of understanding, and all of it is important. And in many ways, although not in every single case, in many ways it's very interlinked. So if you look at that absolute base of mental health in the perinatal period, it is incredibly widespread that people feel lonely. So in a study by Peanut reported that 70% of mothers report feeling lonelier than they have at any other life stage. So that's something very specific to that perinatal period. Then there's this kind of, you might call common category, whereby people may not, as Becca described, meet a kind of clinical diagnosis level of anxiety or depression. But in a really recent survey called the You and Your Baby survey, which is due to be released very soon, and screened against evidence-based screeners for anxiety and depression, between 30 and 50% of people reported symptoms of anxiety and depression in this period, and those rates are going up compared to 4 years ago when that survey was done. Then you've got this kind of, it's occasional, that kind of between 2 and 10%. Again, it depends what studies you read, but it's really important to know that 1 in 10, up to 1 in 10 may be experiencing these challenges, conditions that can be diagnosed by a psychiatrist or others. And I've added eating disorders in there, tocophobia, which is an intense fear of pregnancy and giving birth. And then, of course, the much more rare postpartum psychosis. Becca alluded to this when she was talking about the Embrace study, but organisations like MMHA, like Make Birth Better, the reason we often, we never focus entirely on marginalised communities, as I'm going to call them here, but the reason it's really important that we hold those communities in mind in particular is because the further that you are away from that kind of centre of power, as you can see in this Wheel of Power illustration from Sylvia Duckworth, the more likely you are to experience a mental health difficulty or challenge. So we always have to hold in mind this concept of marginalisation. The less someone has, the more they're pushed into the fringes of our society, the less they're centred even in our brains and the way many of us are set up to think, the more likely they are to suffer. So, positivity, sorry, it's a little bit of a, like this graphic, I just had to put it in. This is a really positive time to affect change, perhaps even relative to adolescents and young people, which is another time that that we often talk about as being a very kind of vulnerable time in life. But the reason it's a really positive time is because we know what the predictive factors are. Okay, and with good screening, good training, trusted relationships, the likelihood that you can spot signs and symptoms and move someone closer to whatever their care or support that they require is really good. Okay. Often this is, in most cases, a chosen life stage, which normally correlates with the fact that people want to feel well. They want to feel well for themselves, for their families, to be able to go back to work, etc. So that plays in our favour in terms of people wanting to lean into care and support. Not always, but it is helpful. Very uniquely, this is a time where all women, so 99% of women and birthing people will book. They will go to their midwifery booking appointment before 24 weeks. Okay, that creates a really unique window and journey through our healthcare services that is unparalleled at any other time of life. Interventions work, you know, the therapeutic interventions, the pharmacological interventions that the likes of Becca and others working in psychology and psychiatry, the work they do works. They wouldn't have jobs if it didn't. The earlier that you take people to this specialised support, the more likely they are to get better. And then also something that I always like to remind people, because it can feel a bit bleak sometimes when we're looking at these topics, and often people go to, oh gosh, there's so much more to be done. And yes, of course there is, but it's really nice to know, I think, that in terms of perinatal mental health, the UK is probably the country that is being looked to globally as a country that's doing this the best relative to other countries in the world. So we really do have something to celebrate, and we're on a really positive trajectory. So why does it matter? Becca covered this too. It matters because it costs. This is a financial way of putting a metric. Anyone like myself, others, I'm sure many of you who've been through these experiences, we know that cost may not necessarily feel like money, but we can quite see how it gets converted into money, because we know how less well we function as human beings when we're mentally unwell, particularly when we're very mentally unwell. And here Becca made this point, but you know, most of this money in terms of the cost relates to the impact that our being unwell has on the child. I just want to put one small compassionate caveat on this, is that it's very normal that we worry a lot about, if we have been unwell, that we may have irreparably damaged our children. I just want you to know that if you're here, if you're seeking support, if you're here in this space learning, you're absolutely not one of those people. It's the people who don't get the help and the care and the support that they need and they deserve, who are the ones that often might see that there's more of a lasting impact on their child. So on to the main part of the presentation is really thinking about, so how do we get care support or access services? There are lots of ways that you can think of care and support and service provision. And in terms of the greatest reach, you've obviously got those population-wide awareness campaigns and tools and symptom checkers that are really, really important. I know in this digital world we can say, oh, no one wants a leaflet, no one wants a poster, but I can promise you they still do. They may want it more as an app or as in another format, but those are really important. Then you've got the concept of universal care, appointment-specific checks. You've got the role of voluntary and community sector pay, and then you've got those statutory, so funded by NHS or local authority, statutory funded specialist services. I put these two in green because these two in green are the two that are the most established in this country. So what does population-wide awareness look like? Or if you work in the system, perhaps you're a midwife or a healthcare professional, what does this look like in your hospital, in your trust, in your maternity settings? Okay. So at Maternal Mental Health Alliance, we have a parent information centre, we have a perinatal mental health symptom checker that you can order online for free. It's a poster. Just launched a new campaign called This Is Also Motherhood, which is all about tackling stigma absolutely head on when it comes to some of the tougher challenges that people can face with their mental health. We have a training program for corporates whereby we go in and we upskill corporations on how they can support their employees. And we have relationships with big brands who have a huge reach, like Tommy Tippy, so that they can get out these messages around perinatal mental health to huge numbers in ways that we just on our own never could. And then here are some examples outside of MMHA on the other side of this slide. So every year in May, there is the Maternal Mental Health Awareness Week led by the Perinatal Mental Health Partnership. Please look it up, take part, be part of all of that digital noise and conversation that happens in that month, because it really, really does make a difference. There's leaflets here that are available for the Royal College of Psychiatry. We're just helping them to be updated, working with them at the Alliance. And then another really nice example here is from Heidi at the Mama Academy. So these are pouches for the folders and for people's notes. I'm sure if you've seen them, that will mean you already use them, but she's got certain ones that are more focused on mental health as well. There are lots of different ways that we can think about that population-wide awareness, and it is really, really important. And actually what we know is that since the government stopped backing big campaigns, so there was a very, very big campaign started about 15 years ago called Time for Change, you might remember it, and then latterly taken on by the Royal Foundation under Heads Together. I think a lot of us remember when William and Harry and Kate first started talking about mental health. Those campaigns are proven to have shifted stigma awareness and understanding within the UK population. We now know that since they're not being funded at the same level, we're seeing our awareness and our levels of knowledge and stigma changing, going in reverse. So the more we do this population-wide work, the better. So these two, universal care, it's a very kind of it's a very healthcare professional concept. What is universal care? What do we mean? What we're really talking about is the whole journey that you go through with those statutory NHS and local authority funded services through the perinatal period. We have one study that says there's at least 16 touch points with midwives, health visitors and GPs across that period. So there's a real aspiration within all of the mental health community, but particularly within perinatal mental health, that we really look at what would it mean for care in the lightest of touch of ways to be integrated into every one of those contacts. Following this idea that every question is an intervention. Every question that someone doesn't open up to, when you ask them again and again, and perhaps another time, another few appointments down the line, you're building trust, just signaling that you're a safe person to talk to. In time, you're more likely to be able to support them with their mental health. So this is very much a vision, and this is absolutely something that's not happening in terms of civ service provision yet. It will be happening in some brilliant pockets in the country, but it's absolutely not happening everywhere. And then similarly, those kind of appointment specific checks. There's some real progress being made here. So within health visiting, for example, within one of your 5 mandated checks, they can place you on what they call a perinatal mental health advanced care plan. You can ask yourself for a specialist perinatal mental health midwife. It's useful just to know that. So if you know you're not okay and you're developing a good relationship with a health visitor, you can say to them, I've been told that health visitors can provide some more support around mental health. Can you help me? Similarly with midwifery, there is more and more integration of sorts during one or more perhaps of those mandated checks where there may be some screening going on. There may be some people asking those brilliant questions in really compassionate ways. And again, just remember, we now have a cohort of perinatal mental health midwives and nurses. So if you're entering your journey and perhaps mental health is around for you as something that you might be concerned about, mention it to your midwife, and there are pathways for support. So then they're likely to refer you to the perinatal mental health midwife or the nurse within their team who can then give you more dedicated support. And then GPs, this is by far the one where we have the furthest to go for lots of different reasons. But in terms of your right and what the NHS is contracted to do, the NHS is contracted to give you a comprehensive maternal postnatal consultation. So that is separate to the consultation that they do for the baby, although sometimes they roll it into one. But that's meant to focus on the mother, their health and their well-being. If you don't get the answer you want from the first GP you go to, ask to see another one and another one after that, if you can, if you have that within you, because GPs are often the gateway to other more specialist services. As I've talked through the next slide, sometimes it helps to know exactly what services to ask for, and then even if they don't know, they can go away and find out. So what services do we have that are funded by our NHS, by our government, and by our local authorities? So we have an incredible network of mother and baby units. Okay, so these are specialist inpatient units for mothers with really severe mental illness. They are not yet completely nationwide. They're more scarce in our devolved nations. Northern Ireland, for example, still does not have one. But they are available and they're out there. Specialist perinatal mental health teams, these are a wonderful development that have been set up within the last 5 years. These are community-based teams that are likely to support you. Often this kind of words about mild, moderate, severe. It's very healthcare professional language, but if your mental health is really disabling you, you're more likely to be seen by those teams. Maternal mental health services, very curious as to why they're considered separately. In some places they may be considered the same, but there are also teams nationwide. Again, this is a multidisciplinary team who have been tasked to specifically focus on loss and trauma. So if you're particularly struggling with trauma, birth trauma, or loss of any description, that's your best chance of getting some specialist help. I've mentioned our specialist midwives, health visitors and nurses. They're always worth asking for. I know they really helped me when I had my third child and was wheeled back into the room where I had experienced my very acutely traumatic postnatal experience after my first child, and very rapidly began to feel not okay. But it was the maternity or the mental health specialist midwife who came to me on the ward, was able to sit with me and talk through mental health in a way that nobody else was able to. You've then also got birth reflection services. So these are run by maternity teams with some kind of mixed reviews, but generally those that do it well do it really, really well. And this can be an opportunity, if you feel able to do it, to review and reflect on your experience of birth within your trust. Then, of course, you must remember that the more generic offerings are open to all. So NHS talking therapies, you can self-refer yourself into NHS talking therapies and you'll get a kind of short blast, if you like, tends to be up to kind of 6 weeks of talking therapy as part of that offer. There are parent-infant teams who are often embedded into these kind of family hubs, and they work specifically around the kind of bonding and the relationship between parents and infants, often using an intervention called VIC, which is where they video you interacting with your child and support you to see how well you're doing normally and to build confidence in that relationship. And then, as Becca said, it's important to know that in cases where there is an emergency, you can contact NHS 111. There is now a mental health option. You can go to A&E, you can call 999. They are becoming increasingly able to support people with mental health difficulties. So last couple of slides here, of course, the voluntary sector. There are so many in here. This is a screenshot of the 160 organisations we have in our alliance. Often it can be kind of hard to navigate what's out there. Go to our website and look at member directory. It's a really good way to have a good old look through all of the support and resources that are available from the third sector. Similarly, Hearts and Minds is specific to mapping support services that are very grassroots. So you can go onto the Hearts and Minds map, you can put in your postcode and it will pop up what the local support groups are to you. Hub of Hope does a similar thing. It's more generic across mental health, but it still works. And then often people ask, but what happens if I just need a therapist, if I just need to know who to speak to? And there are lots of ways to find that out. But again, just a really reliable source. Go to the British Association for Counselling and Psychotherapy, and they have a brilliant directory that can tell you by postcode how to access a therapist, if, of course, you're able to afford to do that. I wanted to give you a couple of specific examples according to these types of conditions or struggles. So if people are struggling with loneliness, with not having enough support, just really needing someone to talk to, look up Pandas, look up Home Start. Both are brilliant. If it's birth trauma, look at Birth Trauma Association, look at Make Birth Better. Obviously, Becca and I are going to say that. If it's loss, Tommy's and Sam's, there are many, many others, but those are the two most well known. If it's people who are experiencing a NICU stay, go to Bliss. If it's OCD, maternal OCD are wonderful. If it's hyperemesis, pregnancy sickness support are brilliant. If it's eating disorders, BEAT are still very hard to beat. If it's bipolar, you've got Bipolar UK, and then PP, Action on Postpartum Psychosis, are also wonderful too. So my last couple of slides, I'm over talking, I'll do these quickly. Alongside active support, we really do have to think about systems change. I know these quotes get used and overused, but it's because they're good. It's because they say something in a way that no other quote since then has done so. We can't just keep pulling people out the river. We've got to go upstream, figure out why people are falling in. And let me just explain to you why in our healthcare system as it stands, so many people are falling in. Okay, so at your 20-week appointment with a midwife, all midwives are going to talk to you about how to prepare for labour or birth. And why? Because it happens in 100% of cases. Okay, it's a natural part of the process. But at no point in the perinatal journey will any professional, much more likely than not, talk to you about intrusive thoughts. But did you know that actually 100% of women and birthing people experience intrusive thoughts of harming their baby? 50% experience intrusive thoughts of harming them on purpose. That's about mental wellness. It's about the brain. It's about the way that we change when we've had babies, but we don't talk about that. And yet it hits the 100% in the same way that birth does. We take blood pressure for hypertension up to 10 times in a low risk pregnancy, because about 8 to 10% of people will develop new onset hypertension, which increases risks of conditions like preeclampsia. But at no point in the perinatal journey will any professional talk to you about spotting the signs of traumatic stress. And yet we think up to about 10% of women, and this is on self-reported basis, self-report symptoms of PTSD after birth. And we train all midwives and obstetricians, of course we do, on how to manage things like amniotic fluid embolisms, catastrophic hemorrhage during birth, because maternal death in a very, very rare cases can happen if these things are not well managed. But we don't routinely train people on suicide prevention in the perinatal period, and yet you are 5 times more likely to die by suicide after giving birth than you are to die during birth. So the system is wildly weighted towards physical health, not mental health. And until we start tackling systems head on, we won't unfortunately see the level of change that we need. That's me.
Thank you so much, Nikki. I mean, as ever, such a really clear overview, and particularly I loved your slides on the sort of psychological and neurological changes within the brain. I think that was really, really helpful. And also, I think in today's world, your slide on the sort of social and cultural and lifestyle factors, I think it captured really succinctly the complexity, and maybe that's why we're also seeing a rise in mental health. But again, I think providing those support pathways and key touch points, we know is going to be invaluable to everyone on this session as well. So thank you very much for taking us through those, and those last few slides were really impactful. So we've now come to the end of our main speakers. I'm going to hand over to my colleague Rebecca, who's going to now chair the Q&A. And thank you very much, everyone, for your questions. So I'll hand over to Rebecca. Thank you.
Thanks, Julianne. Just before we get started, Sally's had to drop off, but we've got an answer for one of the questions put to her that Rochelle's going to talk us through Sally's answer she provided, and then we'll come to the rest of the panel for the other questions. So the question that Sally's provided her response to is, how did your experience of caring for a disabled child impact your family dynamics and your daily life? So Rochelle, over to you.
Thanks, Rebecca. So Sally's answer is my mental health had a very serious impact on my family, as I had to leave home for 10 weeks to get professional help. Sadly, if I had got the help initially, this might not have happened. She goes on to say that life was very stressful, very chaotic. She had lots of appointments for Lexi, which didn't help. She also says that as a mother, she felt that she was letting down her other child. She had an older daughter, and that still makes her feel incredibly sad. She goes on to say that now her children are older, the family tends to be split up because one parent has to go with one child and the other has to either stay with Lexi or take her to a different type of activity because they're not geared to both the children. And she particularly finds going out of the family very upsetting because her daughter's peg-fed. And she doesn't want her daughter to sit and have to watch her family eat when she can't take very much food orally. She can take little tasters, but going for a meal is very difficult for them. And she also says that as a family, they've found particularly access difficulties getting into old buildings. They're not geared towards people with disabilities and access for wheelchairs.
Brilliant, thank you, Rochelle. So we've had a pre-submitted question that is for all of the panel, but Becca, I'll come to you first on this, as it's something you touched on in your talk. The question we have is, I'm so pleased to see the increasing awareness and discussion around birth trauma. I wondered if the panel could give their thoughts on breastfeeding, grief and trauma, as it does not seem to be discussed as much. And we know the UK has one of the lowest breastfeeding rates and the support around that can sometimes be varied. So Becca, I come to you first, and if anybody else in the panel wants to jump in, just do so.
Yeah, of course. So it's a really good question, and absolutely for a lot of people, their trauma is around not feeding in the way that they hoped or expected to. And that can be for a whole range of reasons, but definitely I hear from people that the support is very variable. And I think for a lot of healthcare professionals, they don't realise the impact of feeding trauma can be really profound and really tender and last for a long time. You know, people can be triggered years later by seeing somebody else breastfeeding by them. You tend to see that often people might not be able to feed, because they've been unwell themselves, or it might have felt too challenging, but sometimes people will be desperate to feed as a way to sort of make up for, in their minds, them feeling that they failed at birth. And they often really punish themselves in feeling they have to feed at all costs. So it is a really complex and nuanced issue that I agree we should be training people about a lot more. And also just in terms of support on the wards, it should be much more bespoke to that person in understanding what were their hopes, what has actually happened, what do they need in terms of support around that, because often there is kind of breastfeeding support offered, but that's it's all around breastfeeding and nothing else. So yes, it is something that we need to think about and offer more personalised care around, for sure.
Brilliant, thanks Becca. Anybody else want to touch on that one before we move on to the next question? Brilliant. So, Nikki, I've got a question for you. We're seeing more discussion around birth trauma and maternal mental health in the media, which is great for awareness for individuals who might feel that that's just their situation. From what you see, have you noticed a positive change in people seeking support earlier because of more awareness generally?
Yes. So, I'm just check I wasn't on mute. Yeah, it's a great question. So I was listening to one of the leads within the NHS who was responsible for setting up the maternal mental health services that have been set up specifically for trauma and loss. And when they were thinking about that service, there was an awareness that it might be useful, but it was a bit like, oh, let's just see. All of those services are now wildly oversubscribed. And that's just a small fraction of the number of people. So it's only, unfortunately, there's between the perinatal mental health specialist teams and the maternal mental health services, they're only seeing 60,000 people a year. That might even be over 2 years. I need to double check the stats. The need is very great, and you are definitely seeing people reach out for support. You know, Becca and I saw that, and Becca continues to see that at Make Birth Better. But the people who were visiting our website looking for support, help and understanding were in the tens of thousands every year.
Brilliant, thank you. Becca, this is a question for you. How can midwives and GPs better identify women at risk of perinatal mental health issues, especially those without a prior mental health history before they've had their first pregnancy?
Yeah, so I think for midwives and for all professionals, really, it's just about holding in mind that lots of the people you work with are likely to have some kind of mental health issue at some point, potentially. So just keep thinking about it. And I think it's about giving space to ask questions. Again, it doesn't have to be a full history from somebody, but we know that often people aren't really asked about their mental health throughout their pregnancy in any detail or depth. It's really difficult, right? Because midwives work so hard and they have a limited amount of time to spend with somebody, and they have to get through certain physical health checks. But my thought would be that it's just as important to be asking those questions about how somebody is. And actually, a lot of people don't get asked that routinely at every appointment. The same for GPs is that, you know, in the maternal postnatal check, for example, I read all these reports and notes, and, you know, they go through and talk about all the physical health issues, but there's no mention of how was your birth. And then you read that the person's had a hemorrhage and baby needed to go to NICU for a couple of days, and yet there's no kind of exploration of that. So we have to create these spaces where we give people the chance to begin to say, actually, it wasn't how I expected. I'm feeling really fragile. We can't just expect people to always tell us that. So we need to be thinking about and asking these questions more often for people, and it needs to be at every appointment, really. It's not just a kind of add-on. We need to be thinking about that this is important. We know all these risks and vulnerabilities we've just talked about, so we need to consistently check in with people. If you've got continuity of care, of course, that's much easier. But even if we don't, we should be checking in and asking people.
Brilliant. That nicely answers another question I had about the role of routine mental health screening, which you've nicely touched on, and does lead me on to another question, which is open to both of you, of what changes would you like to see in national guidance or NHS pathways to improve maternal mental health, and potentially routine mental health screening may be part of that, if I open that up for discussion.
Do you want to go first, Nikki?
Yes. I do think we are doing a lot right by comparison to other countries, and therefore having our specialist services set up in the way they are is absolutely more than a step in the right direction. So aside from the fact that we know all those services are oversubscribed, currently at risk from having reduced funding, so there is absolutely a big piece here about protecting the progress and really, I think standing up and being proud for us leading the world and saying it's working, we're going to keep investing and delivering. That needs to happen in our specialist services. But meanwhile, what we know is that the real gap is in this, what's, as I said, often called like universal care. And to Becca's point just there about, you know, the way GPs may in fact, are very unlikely to talk to you about your mental health once you kind of transfer to be looked after in their care. One of the greatest wins for us, or the next big win for us, would be a commitment to the integration of mental health care and support across the whole of the pathway. There are 16 touch points, as I said, with healthcare professionals. I'm not minimizing the barriers. We absolutely understand the barriers and the reasons why there are a lot of reasons why people would say, but we can't. But obviously, we're mental health advocates, so we're going to say we can. We just need to figure out how. And what you would add, Becca?
Yeah, I mean, I think it's we need to kind of be fierce about it. So we wouldn't expect somebody to go to a pregnancy appointment and not have their blood pressure checked because it's important, right? And they are usually, everybody has their blood pressure checked at every midwifery appointment. So why aren't we checking in with somebody about their mental health at every appointment? Because it's actually just as risky, just as important, can lead to the same, very significant and profound impact. And I also, I'm deeply sympathetic and compassionate to the stresses and strains of everybody working in the NHS. And it's, they have very limited time. But I think what we need to do is make it so that the system has time to have these conversations, and that needs funding and looking at staffing and training. And, we need to push for that to be there. It's not good enough to say we can't do this, we should and must do this. And we just have, that's something obviously that we continue to campaign about.
Brilliant, thank you. That leads me on to another question I'd had. You've preempted all my questions, it's very helpful, about the common barriers for accessing timely and effective mental health support for mothers and birthing people, particularly considering sort of cultural and social economic factors. Obviously, your talks touched on this a little bit, but you could give us a summary of those common barriers, that would be helpful.
Yeah, I mean, there's so many barriers. And, I think if we think about, the way services are run and provided, that, there's often so many expectations and assumptions that you speak English okay, you know how to navigate the NHS. We know there's an issue sometimes with translators being provided. We know that culturally the way people talk about distress can vary hugely. Some languages don't use the term depression. So are we really kind of offering that kind of sensitive inquiry and not assuming that all women will present in the same way? So there are so many different reasons why there can be barriers to care. I think it is particular to mental health about the huge amount of stigma that still exists in many communities, families, faiths, whatever lens you look through. There is still, often a fear and a misunderstanding of what mental health services are there for and about. So we have to think really creatively about how we serve communities, because communities are not hard to reach, they're underserved. So we need to be more creative about where we see people, how we engage with people, what kind of support we offer. But, that is a big part of the work that needs to still be done.
Nikki, anything from you on that one?
Yeah, I just was learning quite recently about the kind of in health psychology, the concept of like the health belief model, and it helped me to really think about barriers in a new way. And it was explaining how obviously people need in the first place to have the motivation to want to get better, to want to seek support. So you've got to address kind of motivational issues in people that may think, well, I don't want to get better anyway. You've obviously there's got to be plenty of cues to action, which is where that kind of population-based work comes in. This looks like you see I can't remember how many touch points it is. You have to see something before you act and buy it, isn't it? I don't know. You've all heard that marketing stat, right? But it's a similar thing. So we need to be talking about it in our homes, seeing posters on the walls, seeing celebrities talk about it, our friends telling us about what services they've accessed. The more cues there are around us, the more likely we are to seek help. another one I think is really interesting is we have to believe in the benefits. You know, still, if you mention, oh, I went to therapy, we're so far from the States this way, we instantly judge. We have a very preconceived idea about what psychological support or medication looks like, whether it works or doesn't work. And we actually attach quite a lot of shame, I would say, for example, antidepressant, you know, people who legitimately take antidepressants, there's a lot of shame attached to that. And then there are all those other barriers, which from a cultural perspective are particularly for, you know, racially marginalized cultures and faiths. It is really important that we do not create a panacea and we think that everybody understands mental health in the same way. Becca and I worked on this a lot at Make Birth Better, but within South Asian communities, for example, they might tell us, but there's no word for mental health. There's no actual framework in our language to talk about mental health. So you're overcoming a lot more than just, you know, the average stigma, the fact your friends are not talking about it. Those are very like white middle class views of the world. To really understand it, the cultural barriers, we absolutely have to go in and fully engage and understand what are the reasons that change is not happening at the same rate, and how do we address them, and how do we empower those people who are doing amazing work already at trying to address that in their own communities.
Brilliant. Conscious we are coming up to time, so I'm going to sneak in one final question. Becca, your talk was really useful in terms of identifying sort of the key symptoms to look out for in new parents from those who support them. What's the best resource if somebody is concerned as to where to look for those key symptoms to keep an eye on? Is there a leaflet that's provided, your GP? Where's their best starting point?
So I mentioned the kind of downloadable at the Make Birth Better website, which has it basically has a list of symptoms where you could perhaps sit and think, I am feeling this, this, and this, and tick them off, and then take it with you to your GP, to your health visitor, to your midwife, to start that conversation of, you know, I've noticed that I can't sleep, I'm having nightmares, I feel really on edge. And then that can just start a discussion around that. I think, you know, there are lots of different places online where there is amazing information, like Nikki resourced on her slides, those specific organisations for different kind of experiences. There's also a lot of noise and rubbish information on the internet as well. So I think, you know, trying to speak to a healthcare professional if you feel able to, because they will be coming from a position of really knowing about the different conversations. But I think other things can be things like the peer support helpline, so things like pandas, which, you know, if you're just not sure what's happening, can be a really good starting point as well to kind of have a conversation with somebody. It's very non-judgmental, it's confidential, and it can perhaps start that kind of signposting as well.
Brilliant. Thank you very much to all of our speakers today. That's been really helpful. I'm conscious that we are at the end of our allotted time, so I'll hand back to Julianne now for closing. Thank you, everybody.
Thank you so much, Rebecca, and everyone that on our panel members. It really, you know, really fantastic discussion. So we've come to the end of time now. So just want to say thank you, everyone, for attending our webinar today. A real huge thanks, though, to Sally for sharing her story, and to all our speakers today for giving up their valuable time, you know, sharing their knowledge with us all today. I know at times it's felt a little deep and hard, but I think we also went through lots of really green shoots about, you know, what we can do and what support and all the fantastic organisations that are out there as well. So just a couple of asks for us, if that's okay, for attending the webinar. If you can complete the feedback form about how you found the webinar today, it does really help us to sort of shape our future webinars for that they are actually what you want and what you find helpful. And it also helps us to plan that future content. Over the course of the next week, you'll hopefully receive the link to the recording from today's webinar. Hopefully, we're going to try and put on as well the links to the charities that have been referenced in those talks and any organisations where we can. So you've got easy access to them as well. Now, next year we'll be also holding 2 more webinars as part of our Maternity Matters series, and we'll share those details about the contents of those webinars in the new year. And then finally, just to say thank you all to everyone that's attended. We know how precious people's time is for joining us today, and we just want to say thank you again and enjoy the rest of your day. Thank you and bye-bye.